And we know that especially for healthcare workers and the healthcare industry, we're especially affected from all sorts of different sides with the basically restructuring of the government and all that's happening. So we're not a political organization, but we understand that politics is a part of everything and especially a part of healthcare. So we're not blind to it. We're not blind to the fact that a lot of people are hurting. And for those of you out there who are, we just want to know we see you, we are with you, we are you, and we're gonna figure out a way to get through all this together. So we've got work to do, and we got to keep our heads down and keep working on it.
Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am the production editor, Grace Pratt, and I am joined by our full team of co-hosts today, which is so exciting because we have a really good conversation. And I know it's really good because it already started in our planning chat for the week. And I just was like, I can't wait to hear more about this. And so we are bringing it to your earbuds for this podcast episode. We are going to start with our introductions the way we always do, except instead of the icebreaker during the introductions, I'm just going to have you guys introduce yourselves, and then I'm going to do some rapid fire on the spot, either or preferences questions. We'll see how they go. So as we're introducing ourselves, though, first around the circle from me is, oh my God, Jen.
Good morning. We're getting going. Hi there, Jen Thomas, Family Medicine, Addiction Medicine, Morris Hospital, also medical director at CFHA. And yeah, happy to be here. Am I supposed to jump into rapid fire or let them introduce first?
Because you don't know what the question is yet.
All right, yes, I'm reading your minds. I failed.
If you have a favorite, I'd be grateful to hear it. But
next we got slow fire. We got slow fire brains today.
All of our brains are coming online. Yes. Hopefully they're coming online. We'll get there. About 15 minutes. Next, we have Bridget Beachy.
Name is Bridget, and I'm a director of primary care behavioral health in the state of Washington at FQHC, and involved in a lot of things related to integrated care and PCBH.
And then Neftali Serrano.
Hi, I have to apologize. I live in an area with a lot of birds, so if you hear birds in the background, that's why. I'm gonna mute when I'm not talking. I am Neftali Serrano, or Neftali Serrano. I am the CEO here at the Collaborative Family Healthcare Association.
Excellent. And Monica Harrison.
Birds are whimsical, Neftali. Monica Harrison here, clinical trainer, implementation coach with the AIMS Center, as well as one of your CFHA board members and fellow podcaster.
And I'm Grace Pratt. I am the behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. Okay, so here's the questions I have for you. Just top of your head first.
I'm nervous. You haven't even started. I'm just nervous.
You're fine. The mountains or the ocean?
Mountains.
Oh, ocean.
Ocean.
But you didn't say, Grace.
Oh, ocean. Yeah. Salty or sweet?
Ooh, salty.
Sweet all day.
Savory.
Oh, look at Neftali.
Sweet.
Salty for me. Okay. Coffee or tea?
Tea.
Coffee.
Neither.
Bridget, you can't get down with some tea?
Dude, no. I hate tea. I hate tea, and I don't like coffee, and did like energy drinks.
Hold on, but I'm caffeinate in another way. Oh, energy drinks. Okay, because I was gonna say, if you have all this energy with no caffeine,
where's it come from? What's the secret?
I'm on day 5. No energy drinks, no caffeine. So awesome. I'm going all caffeine free.
Okay, I like it.
Neftali, coffee or tea?
Tea, but decaffeinated.
Okay, coffee for me. Spring or fall?
Spring. Love the green coming back.
Spring.
Fall colors for me.
Fall.
Cake or pie?
Pie. I'm a pie person. Come on.
Between that. Like, who would make someone choose that? What did your mother do to you when you were 5?
Cruel.
Like, who would make someone choose between those two things?
Cake or pie, Monica?
Dang it, cake.
You gotta pick.
Yeah. Cake for me too.
Pie.
Okay, cake for me. Cats or dogs?
Ooh, tough
Mm-mm.
one. Dogs, I guess.
Neither one of them. You got to clean up behind them. They're like children. No.
Yeah, neither one.
Neat
Neither.
lizards, bearded
There
dragon.
you go.
I
I'm
knew what your
visiting
answer would be,
Bridget.
Bridget.
Visiting Bridget's lizard.
Okay, cats for me. And then last one, robots or dinosaurs?
Ooh, robots, I guess. Ooh, tough one. Robots.
Robots could be helpful. Robots.
Yeah.
I'm a
Yeah,
little
I'd
afraid of
go-
robots these days. Maybe I'm going to go dinosaurs.
I'm going robots
Dinosaurs.
too.
I
And
feel
the
like
robots will take over the world, but the dinosaurs would too.
well, I'm kind of like I've been watching all of these shows lately about AI and what's forthcoming, and they're all the
Mm.
takeover movies
Mm.
where the AI takes over your family and all of these things. So I feel like I should probably say dinosaur because it is a little bit scary, but listen, I'll be gone by the time we get there, so I'm gonna go robot. My kids deal with that.
It's next generation's problem.
Yeah, next generation.
Yeah. So thanks for humoring me. I think that's really fun way to kind of hear all of our different preferences. And spoiler for something coming up, we all have different preferences. We all have different alignments. We all have different pieces. And that's going to be relevant to our conversation here in a minute. But first, before we get there, Neftali, do we have any news and notes?
We sure do. Yeah. So one thing I just wanted to say off the top is that I just wanted you all out there to know that we know what's going on in the world. Like, we're not ignoring it. We know that stuff's pretty messed up right now. And we know that especially for healthcare workers and the healthcare industry, we're especially affected from all sorts of different sides with the basically restructuring of the government and all that's happening. So we're not a political organization, but we understand that politics is a part of everything, and especially a part of healthcare. So we're not blind to it. We're not blind to the fact that a lot of people are hurting. And for those of you out there who are, we just want to know we see you, we are with you, we are you, and we're gonna figure out a way to get through all this together. So we've got work to do, and we got to keep our heads down and keep working on it. And there will be some tangible things that we try to do to help our community, do our very best to keep with our mission, right? Which is providing the highest quality patient care in a team-based format. So I want to let people know that. The other thing is that we have a couple of really big events that we want to make you aware of. And it's pretty timely for those of you who are listening to this podcast, because probably by the time you're listening to this podcast, the deadline for the call for proposals for a conference in October in beautiful Raleigh, North Carolina, is in mid-March. So that means you need to get those submissions in. Go to integratedcareconference.com, click through the call for proposals there. Now, while you're there, you will also see that we have a pediatrics masterclass. And this is an event that we are hoping is a big event for our members and non-members alike to come and upskill their skills to help support our children and families. And we chose that very intentionally because we feel like children and families are particularly affected in our current political climate, including especially a lot of marginalized folks from marginalized backgrounds. So come get upskilled. Make sure that you're ready to have full toolbox of interventions at your disposal for your sites. That's what this event is about. We've got 4 great pediatric experts leading this masterclass. They're fantastic people. So yeah, so this information's on that site, integratedcareconference.com as well. And that's our news and notes.
Thank you, Neftali. And thank you for, starting us off with those words of just acknowledgement of the time that we're in. We know that our podcast, our episodes stay around and people listen to them at all different times. And we've been through a lot of different seasons together in this podcast. And we don't want to not stop to acknowledge that. And hopefully, at some point in the future, someone listens back to this episode and thinks, oh, that was a dark time and look how far we've come. So speaking of our podcast hanging around for a very long time, longtime listeners will remember that one of our first episodes was about models in integrated care. And you had to go way back to find that episode. I think it was in the first set of 5 or 6 that we did, the first 6 months of having the podcast. But one of our co-hosts in our planning area this last week said, hey, there's a spirited conversation happening on the listserv, as it does. I think this conversation about models and ways of working is sort of a perennial one for us. And it comes up and people have big feelings and a lot of opinions. And we also note that among our co-hosts, we have a really brilliant group of minds here with lots of different experience and application of different models in different systems and different ways of working. And so we thought we might shine a little bit of a light on that conversation, share some of our thoughts, and just see kind of where we're landing these days in 2025. I almost wrote 2024 yesterday, but I caught myself in 2025 thinking about models. So I wonder if anybody wouldn't mind kind of recapping. Maybe I know that we find some listeners who aren't a part of our organization yet. You should know that we have an incredible conversation on the listserv, and it's one of my favorite benefits of being a CFHA member is hearing like the just absolute generosity of our members to share their ideas, to share their thoughts, to engage in really thoughtful, respectful discussion, even about things they have big passionate feelings about. But I wonder if anyone could maybe start by recapping a little bit of what that conversation has been lately that prompted this episode happening now.
So glad Neftali raised his hand because I'm like, I feel like I missed a piece of it. I was on vacation, so I kind of jumped in towards the middle endish. So recap for me too.
Yeah, I'll recap and I'll also give history. I think that's the part that I'm excited to provide is just context because I'm old. And I was there pretty much at the beginning. Not quite, but pretty much. So for our listeners, if you don't know what even models are, right? There's actually a lot of people who don't have any clue, even if they're in healthcare, what models of integrated care are. So basically, we have ended up with two basic models or approaches to team-based care to solve different kinds of problems. And historically, these models got their start in the mid to late 90s. And around the same time, even though they had absolutely nothing to do with one another, the people involved were not really connected to one another. But it was around the same time that they're working on this. And also sort of ironically, because they were kind of around the same part of the country too, the Pacific Northwest. So, the first model I'll talk about is the collaborative care model. And that model was started really, basically it mimicked the diabetes collaboratives that were forming at the time. So basically, we being primary care, had acknowledged that we weren't very good at managing chronic illness in primary care settings because chronic illness demands a lot of continuity and a lot of follow-up on a lot of detailed work. So, with the diabetic, they need to have their eyes checked, their feet checked, their hemoglobin A1Cs checked regularly. And in primary care, we're so like visit to visit that it's very easy for patients to get lost to follow up. Like if they don't show up, for example, you might see a patient, have them say, hey, come back in 2 months, but they don't schedule. And then you see them back the next year, right? And for a chronic illness like diabetes, that's a bad thing. So the folks behind the collaborative care model had this awesome idea and they said, wait a second, we're developing these registries for diabetes and we're developing these protocols for how often you're supposed to do certain things to care for diabetics. Let's do the same thing for depression. And that's where the collaborative care model was birthed. So I'm not going to go into detail on all that because you can look at other episodes on COCM, but that's the nuts and bolts of how it started in the 90s. It was really trying to solve the continuity problem and the fact that we lose a lot of patients to follow primary care for chronic illnesses. Around the same time, another problem was being identified, which was there's just a lot of people for just general behavioral health stuff that don't get their needs met in the specialty mental health sector, but they're coming here to primary care trying to get their care from their PCPs. And the PCPs are trying to send the folks over to specialty mental health, but specialty mental health is long wait lists, and there's a percentage of patients that actually make it over there, right? So some folks, particularly Patty Robinson, Kirk Strassel, started experimenting essentially with this idea of actually bringing a behavioral health professional and specializing them for the primary care setting. So they act as consultants in that setting, and they're right there with the physicians, working side by side, often working in warm handoffs, taking patients right away, right? right there immediately. So both those models got started around the mid to late 90s, and they sort of grew up in parallel. They didn't talk to each other for much of that time until I would say about maybe 4 or 5 years ago, where now what you have is a lot of folks trying to blend the models, trying to say, hey, we want to run PCBH and COCM, or we've got a COCM program, can we tack on a PCBH program? So that's where this model discussion happens. Now, historically, the real competition has not been, it's not been like a battle of like the models per se, because the models actually do very different things and they have different personnel. COCM has a psychiatrist and a care manager. PCBH has a licensed mental health professional, right? And they're trying to do very, very different things. But I do think that there's been competition over things like attention, right? And with attention funding. So there's been competition over the years around like trying to get government grants or foundation grants, or just sort of, again, trying to get that sort of general public attention. So the listserv conversation was basically a bunch of people who feel a little burnt out on the conversation at all. And they're like, wait a minute, I just don't want to have models. I want to have like, and this is the thing that I don't kind of, I think we'll talk about as a group. I'm not sure what replaces models per se, but I think these folks were saying, hey, there's something bigger than these individual models that we call integrated care, right? And so talking about that is really important. And having these models sort of fight for attention from one another maybe isn't just the most productive thing. And I think that was just a general tenor of the conversation. So there it is. There's my history and catching you up to date.
So immediately get practical. I know that each of us has had experience with this conversation, because the conversation is not just the conversation, it's the principles behind it of the ways that we're working. And we're talking about really operationalizing a kind of unwieldy concept of like, how are we trying to push towards a paradigm change in healthcare? And I love that you highlighted, Neftali, that these groups developed separately, but at the same time, really kind of in response to, I just love I love how creative people are. I love how when there's a problem and different people are coming to approaches of figuring out like, how can we solve this? And so, but truly, this is about the actual work that we're doing. And I think when we get lost sometimes in the bigger question of it all and the theoretical. And so I'm curious kind of what impact has this had? How do we each relate to this conversation about models, or what's the approach that we're starting from? That might be some helpful back again to context for our listeners.
My brain goes to just you don't know what you don't know. I'm thinking back to my integrated care journey as a family physician. This was like 2018. I didn't know the term integrated care. I just knew I was a family medicine provider drowning in need in a, nonprofit, rural, high needs, high Medicaid population. Like, help, we got to do something. The first model I was exposed to was collaborative care model, not because it's, better, superior to PCBH. It was just, I was at a conference and a psychiatrist put up the triangle and talked about having extra teammates for the PCP. And I was like, cool, that could help. So I don't think that the PCPs, at least in my opinion, have any like loyalties of like, one's better, one's other. They're like, all hands on deck. Like, we need help with everything. So like, sure, you got a flavor of integration, come on down. So I guess if I had a time machine, I would have loved to start with a general knowledge of integrated and those pieces of the elements of integration, because I think, at least in my journey, it was okay, we had this idea of, hey, we could do this. And then we had to do the change management. Then we had to do the systems work and say to leadership, let's do something different. Let's hire somebody and put them in a family medicine office. And from the get-go, it was, okay, what is this? Did you just make this up? No, this is evidence-based. There's 90 plus randomized law trials. But you have to kind of educate your colleagues and maybe your superiors while also being a change agent and learning yourself, and that's a very difficult balance to walk. So I don't know, I guess just for my 2 cents, it would have been nice to kind of have a level set, and I hope we're getting there. I hope, the next generation of family docs is like, yep, I've heard of integrated care, I understand the continuum and the spectrum and how it all plays together nicely. So I'm hoping that that's coming down the pipe.
Well, I'll add in just that I think you mentioned something that reminded me that one of the early sort of competitive things was the way the models arose. And I think that speaks a little bit to how culture is part of this, as we're dealing with a lot of that in our country at large. Culture matters. And the collaborative care model arose out of an academic culture. It arose out of research trials in academics. And PCBH arose really as a grassroots model. It arose out of clinicians trying to figure stuff out. Literally, for me, as one of the first generation of clinicians, I literally was figuring stuff out without any evidence base. In fact, I had huge imposter syndrome because there were so many rules that I was breaking when I first started out. Rules like not doing an intake, rules like not doing a 50-minute visit, rules like, intervening rapidly, expanding my scope so that I had a good knowledge of medications and could help guide physicians within my scope of license, but still, so there's lots of things like that PCBH sort of grew out of, because essentially there wasn't a literature base upon which to make these decisions to begin with, right? We were just really talking about a lot of traditions and a lot of norms, essentially. And so the models kind of started talking back and forth to each other initially. People would talk back, and, people on the PCBH side would throw over to the other side and say, like, well, but, you guys aren't, real world practical. And then the collaborative care, you guys have no evidence, right? And both were true to an extent, right? I mean, we didn't have a lot of evidence on the PCBH side, and there was early on there was some impracticality to the COCM model. Early on, I know there's some folks who do revisionist history now, but early on, COCM had very little behavioral health intervention. Like the behavioral, it was mostly registry with psychiatrists and a lot of medication stuff. That was what kind of early on it looked more like. And so there was good things on both sides to be able to say, like, yeah, you have flaws. No duh. We're trying to solve a really hard problem here. We really are. And I'm glad that we've gotten to a point now where, like, I think the conversation between the models, I think, is a pretty tired conversation, because it's like, we're just trying to solve things. We're solving them imperfectly. Like, PCBH is not good for everything. Neither is COCM. We're just trying to solve these issues that these models are specifically designed for. That said, and I want to hear from the rest of you about this, because I still like models from the standpoint of they are absolutely essential to tell people what to do. And when you're on the ground talking with actual real people, you can't get theoretical about integrated care. You can't be like, we're here to do team-based care. We're going to work together. No, like, you need to tell people, this is how you take a warm handoff. This is how you work through a consult. And if you're a care manager, this is your responsibility. This is how you have to manage the registry. This is how you intervene on the phone if you're doing telephonic work. This is how you meet with a consulting psychiatrist and have an efficient meeting. Like, you need models to help you just do specific stuff. I don't think that negates the larger conversation. The models are not integrated care. Integrated care is a bigger thing, and there's more to be done in that space. The models are just instances of integrated care. So I don't know. I don't know if you guys disagree or agree with that. That's the way I absorb that conversation.
Yeah, it depends about all on the setting, the organization that you're in, what the purpose of the organization that you are currently in. Because if you think about it, primary care behavioral health model, so PCBH model, is has been developed for primary care behavioral health. Now, that doesn't mean that if you're working in a specialty diabetes clinic, working as a behavioral health consultant, there couldn't be some overlap in some overall focus, but it's a completely different setting. And you have to, the very first thing we do in our PCBH implementation lab is we have people check with their organization's vision and mission statements. And then they look at their integrated care vision and mission statement. And then we kind of see how can we get alignment and how does this make sense? And how can we speak in the language that makes sense? So yeah, I kind of feel like it's a tired conversation about like, I'm not interested in like putting down another approach, or if somebody works in a diabetes clinic and they're doing PCBH-esque things, like I don't know, I don't lose sleep over what other folks are doing. I just know that if you are working in the primary care setting and you're trying to do primary care behavioral health, you need to have a philosophy and a lens. And that lens gets started with core principles and then goes down from there, like Neftali is saying. And so, yeah, I don't know. It was just interesting because like Dave, everybody knows that Dave and I made the PCBH Life t-shirts. And it was just kind of
Oh yeah,
funny.
Neftali forgot to mention the t-shirt.
The t-shirts part,
That
yes.
is the
And I
part
have
that
one.
kinda-
I have a
that's what
PCBH
spiraled it.
t-shirt, and I've only done COCM, just saying. Because it's all good, right?
Yeah, the t-shirts, and I get it. It was a
Yeah.
hook. It was a
Yeah.
hook to get people introduced, but it was like, oh yeah, you got the t-shirt, and now we have PCBH Life t-shirts, and so like when I read that on the listserv, I was like, all right, cool, like really cool. Because anybody who knows me, it's not about. I'm not against things. I'm for things.
Mhm.
So my expertise is primary care behavioral health. And so I made a t-shirt called PCBH Life. And sometimes it's just about the t-shirt and there's not something more to it.
So
And
just
end of the day,
to provide
And who
context,
had the other t-shirt? Because I'm like, well, I work for the AIM Center, so I clearly should have had a collaborative care t-shirt on. Who had those? I didn't even know who had them. I had an integrated care t-shirt, but
that's
clearly
right.
I was supposed to have a collaborative care t-shirt. Where they at?
I think something you just said that's really important, Bridget, that I want to highlight and builds on what Neftali said of models, like the place where they're useful is giving us a map, giving us the practical implementation guidelines, and giving us language to speak to each other about what's going on. But to the extent that they get used for exclusion and for, well, this isn't, you're not really doing it, and this is our class, you can't sit with us. Like, collaborative is in the name, people. Like that is not the ethos of the whole point of everything that we're doing, you know. And so I think that's really important for us to sort out, is where does our rhetoric divide us versus where are we leaning into just practical, trying to get a handle on what it is that we're doing and what makes it work.
I don't really think it's the models that divide us. I think it's us,
Mm.
right? Like it goes back to me to even the push and pull and tug with our different disciplines, right? Like all of us on here represent a different, right? And so that's a whole nother podcast for another time. But even that, right, of who could do what and which one is better, and well, this one is better for this. Well, no, it's not which one is better. And guess what? I am a social worker. I'm a licensed clinical social worker. No, I don't know everything. So sometimes I got to call my fellow LMFT and be like, hey, so how did this go for you when you were working with families? And sometimes I have to call my PsyD friend and be like, hey, so now when you're assessing and you're thinking about which assessment tool to use for how does this work? Because no one discipline knows everything and can provide everything to every patient. Neither does one model. It is about a continuum of care. What do your patients need, and how can you make sure you are meeting your patient's need? That might be PCBH, that might be collaborative care, it might be some combination of both, or guess what? It might be something that doesn't quite fit with the fidelity to the model, right? Like we're talking about a continuum and meeting your patients and providing services to them that are needed. So a lot of times, because I've done both, I started with doing PCBH before I even knew what PCBH was. I was just out there trying to make it work, trying to give people what they needed. And then I was like, oh, this is like a thing. oh, well, let me learn all about it.
Mm-hmm.
And crafted PCBH and tried to stick to the model and okay, no, it's supposed to be like this. And then along came all the research and data that came out around impact, which was collaborative care. And I was like, oh, well, this helps with these population of patients. How do I make
Mm-hmm.
all of this work together? And there were still
Mm-hmm.
some patients that sometimes needed something outside of those two models. But I
Mm-hmm.
agree, it's important to have language because what I recognize happened a lot in situations where there was no roadmap of this is how you do it, this is how you do this, was people saying they're providing interventions, but just sitting there in the room with
Mm-hmm.
patients, not
Mm-hmm.
providing, listening, but
Mm-hmm.
not really providing any type of interventions and not really understanding how. So the roadmap is needed. So I don't think the
Mm-hmm.
models are the problem. The models are there to give the roadmap. The models are there, depending on your organization. So all that stuff Bridget was talking about in terms of what's your organization's vision. You also need to figure out what your buy-in is from your PCPs, because if you don't have that buy-in, whatever you're trying to do isn't going to work. But I've
Mm-hmm.
been in some systems where they're like, no, we've been doing PCBH forever. We're not trying to even do anything else. We don't like what?
Mm-hmm.
We don't even want to do that collaborative care stuff. Or opposite, we do collaborative care. We have billing codes for collaborative care. It's easy for us. We don't want to talk about anything else. And so
Mm-hmm.
having conversations and educating individuals on what the bowl of integrated care is. We did it was a couple of us, myself, Verna,
Mm-hmm.
Laura, and Tisha, did a
Mm-hmm.
session at the conference, the CFHA
Mm-hmm.
conference a couple of years ago. And we said,
Mm-hmm.
it's different fruit, but it's all fruit. Like we all in the same bowl. We're just different fruit in the same bowl. So what do you feel like eating today? You want an apple? You want an
Right.
orange? Maybe you want both because you like both. Like it's not about having to necessarily choose unless you have organizational requirements that are
Mm-hmm.
pushing you that way, which is
Mm-hmm.
why I say the problem is not with the models. The problem
Mm-hmm.
is with us and our lack of either educating or what
Mm-hmm.
we have internalized or interpreted as some type of discourse.
Yeah. Yeah, and I go to my brain goes to the fidelity piece. I don't know if Grace, you invented the rubber fence analogy, but I'm saying that all the time now because you have to have some fidelity, right? Some workflows of here's how you take a warm handoff or here's how you have a registry, but then you also have to have the stretch of real world implementation. And I think that's where I was very misguided as a PCP launching COC. I'm like, wow, look at the database, look at the data evidence, right? There's like 90 plus randomized controlled trials. This is amazing. We'll just plunk this little thing in a PCB clinic and we'll have all these beautiful outcomes. No clue about how change management systems work was going to be, how it's messy and long, and just really did not understand what we were getting into as far as applying it in our setting. And I think that's my biggest takeaway, having done this a few years, is just like, okay, yeah, models give you the roadmap, and yeah, you got to think about fidelity, but boy, you got to be sensitive to the individual culture and the system and who already is in the system doing the work so that you're not turning off potential allies by saying, oh, we're doing only this approach that excludes a PsyD or whoever else is already on the team. That's hard stuff, especially if you're a learner. My system, we're still new at this, and we're always trying to figure out how to implement it and grow it in a way that is reflective of the talent and the people, the workforce we have in our system, and then also following the fidelity or the model, because there's challenges with panel sizes and how long you can be in an active episode of care. My biggest challenge as a PCP is we don't have that higher level of care that's equal or easily accessible. I don't have that's why we got into the integration game. I don't have a psychiatrist I can send all my SMI patients to, so we get into this full panels. We've got patients on there with bipolar and severe trauma, and it's like, is that really COCM because it's not mild, moderate depression? Well, that's what I have in my clinic. So these are my people. This is the population in my county, and I'm trying to help them with all this. So yeah, the model's good, but it has to be part. It's the yes and. It's the do some of this, do a little bit of this, then maybe you get something that actually does something good. That's just my 2 cents.
The
Yeah.
continuum, because sometimes you don't have certain resources and there's nothing that says, and actually in the collaborative care research, there were patients with SNPI. Like, so
Yeah.
it's just that
Yeah.
part
That's
of like
part of it.
the continuum. Sometimes
Yeah.
you have patients that need a lot more, and sometimes you don't. Sometimes they just need a little
Yep.
push. Things are
Yep.
stressful. Me, patient, hello. Like sometimes
Mhm.
it's that. But
Yeah.
if you are sticking to we're only going to do this and that's it, what about the patients that fall outside of that? And what are you doing for
Correct.
them? So it's not, to
Correct.
me, it's not bad if you do say, I'm only going to do this. But then I say, okay, now what about the rest of the patient
The rest of it,
population?
because we need help with
How are
all of
you
it.
helping? Right. Like, how are you
Yes.
helping them? Where are
Yeah.
you sending them? What does that process or flow look like so that they're
Mhm.
still getting what they need as well?
I think sometimes the people that this conversation really raises the hackles of are our really stringent research friends. And I can understand that we need evidence for what we do. We have to prove that it works. And when we're talking about research, a lot of times we go to, I have this huge soapbox for our residents because they're all like, can you do CBT with this patient? I'm like, yeah, I can, but CBT is not the only therapy. CBT is really easy to study and sure it works, but it's not the only way. And I think that, when we want to prove those like the medical analog of this is the gold standard, the exact random controlled trial, but that study was done with like 14 people with these exact characteristics. And then also we can't get that medicine here. And also my patients have these other cultural concerns and also, right? And so while I understand, I got a PhD, guys. I wrote a dissertation. I've taken many statistics courses and research, and I understand the need. But also, when we take a narrow lens of research, even specifically, and when we aim for, ooh, I might get some mad emails about this. I don't know. I'm going to keep talking, but you guys stop me if I need to.
Go for it.
We're
When
not
we
gonna,
take
we're the
such a
last ones
narrow
to probably
lens,
stop you.
Yeah,
Go
like at
ahead.
this, yeah, like
Like, that ain't
finally
gonna happen.
we're like,
listen,
let's get Grace under fire. Is that a
when we take a
Um,
narrow lens of research in that way, it's a very top-down, power privileged perspective on the ways of having knowledge and naming knowledge. And that is a problem when we are ignoring all of the community participatory based stances, when we are ignoring qualitative data, when we are ignoring these pieces of putting people first and the stories of people and the stories on the ground in favor of a really clean data set. That really gets to me. And I think that is often a part of what's driving some of this conversation and what's driving some of people's real passion for why they feel so defensive of the need to have such a clean way of working, such a specific, hardened process and fidelity to models so that they can prove it. And proof is important and data speaks, but also it is not the be all end all and it's not the only way of knowing. And I think that is part of the conversation here of, elevating the voices of the people who are most affected and elevating, whether that's the clinicians, whether that's the patients, especially patients who, we're trying to meet patients through integrated care. One of the beauties of these models is that it busts through all of those barriers to treatment and it puts clinicians where the people are. And we're not even talking about like community health workers right now and all of those other pieces of, when talking about models, all of the pieces that it can, we referenced earlier that there are many different ways this can look. And we didn't talk about like the amazing work that's being done in migrant seasonal farm workers, for example, that maybe doesn't cleanly fit a PCBH because you're not in a clinic, because you're in a field, et cetera, et cetera. But I just think that it's really important for us to acknowledge that like data and research, of course, is important. Of course, we need to be using evidence-based practices. We need to be doing things that work. And there are many different kinds of evidence. And when we champion something too hard, we lose sight of the core of why we're doing it.
Or maybe another way of saying that is we lose the context, right?
Full circle.
Look at it, Bridget. Yeah. So I think that's the solution in a sense to the conversation, and why I actually like that it comes up once in a while, because it reminds us there is a larger context to the models, right? And again, in my head, people can call it different things or whatever, but I think to me the larger context is team-based care, right? In the end, what we're trying to do is all work effectively together in a way, and all of us includes the patient as part of the team, right? So we're just all trying to work together. We're trying to make this work in a way that leads to a health outcome that is desirable to the patient in a way that's also sustainable for the team, right? That's the context. So in that context, there are going to be a lot of edge cases to our specific models, right? Bridget and I, as PCBH folks, know there are lots of edge cases in PCBH. You get that patient that was just discharged from the psych hospital with suicidal ideation to your
Yep.
front door, needing refills
Yep.
on all their antipsychotic and mood stabilizing medications
Mhm.
with absolutely no care anywhere else. That's an edge case. Is that a case that's like, primed for a PCBH? No. And we gotta be part of the team, right? That's the context that goes in my head. My head is like, all right, I don't have perfect solutions here. I don't have all the resources. I don't have an ACT team around me, right? Which is probably what that person probably needs in that moment. But what I do have is a team, and I know that I need to be an effective member of this team. So how can I adopt or use some of the principles that I use in working as part of this team to be helpful, both to the patient and to my teammates, right? How do I do that? Those same edge cases happen in COCM, right? So in other words, we need the models, but we also need the context around those models. And we need to understand those so that we do, as Monica said before, even if we're trying to focus on a certain group of people, we acknowledge that there's other people. And we have like some idea when we have those edge cases, what are we going to do, people? How are we going to help each other? How are we going to help this patient? Right? That's what context does for you.
And to be honest, like I never saw those edge cases as not being part of the model. And I know what you're saying. And I guess maybe because of, and Dave put this on the listserv. He's like, I don't even know if we do PCBH. I don't really give a shit if I do PCBH to a certain, me being provocative, to a certain extent. Because what I do when I show up every single day and run this program and do my BHC work is I say, how can I help Community Health of Central Washington achieve their mission, which is to provide service to underserved people and have a healthy workforce? And can I help, our stakeholders? The stakeholders are all the team members and the patients. And the BHCs themselves, that's another stakeholder. So basically, I have three stakeholders: BHCs themselves, which is like the specific behavioral health workforce. Then our PCPs, as well as all the medical team members. And if you go real broad, you can go all the way back to like, billing, coding folks and behind the scenes folks. And then third, the patients. And so what I do is identify my North Star, which is the 4 C's of primary care, and gather. So how can I be a generalist, accessible, team-based, highly productive, and educator, and have behavioral health be routinely part of this? And if something, quote unquote, falls out of that, outside of that, to me, it doesn't even fall outside of that. So somebody with severe mental illness who has no meds, no care, and they're highly suicidal and they show up on the PCP schedule, for me to go see them, I feel like I'm a generalist, I'm accessible, I'm team-based, I'm highly productive, I'm an educator, and this is normal. This is routine. So to me, there's no like internal tension. And I think that most of the tension that people experience is because of an overly rigid, back to Grace's point, understanding and thinking that it's a model with a capital M instead of looking at it as a philosophy. And a lot of people put on the listserv a North Star. And so the North Star that I have all day, every day is 4 C's of primary care and gather. 4 C's, gather. 4 C's, gather. And it's funny when you do that, how little tension you have. And so, like Dave said, that's what we do. And if that's not PCBH, then so be it. I don't really care because I'm all in on primary care. I'm all in on helping my organization, and that's my only North Star.
Love
I
it.
shouldn't
Love
say
it.
that because I'm like, well, we don't do a registry. So
Yeah.
No,
I
I'm
mean,
talking out two sides of my mouth. You
you're
need
still,
both.
no, I think what you're saying, Bridget, I think part of the advantage you have is that you're a contextualist, right? I mean, this is contextualizing is normal activity for you in everything you do. And you can be a contextualist and just philosophically, and it does give you that sense of like, oh, there's nothing outside of this, right? Because everything is in a context and I'm going to operate in that context. I'm not going to ignore the context outside of me, right? And that's what you do, I think, pretty naturally. And that's a take home for our listeners, I think. Just understand your context, understand your context as an individual professional, your role on the team, your team's role in the organization, what you're trying to accomplish with your models, and the context outside of that, right? All of that should inform how you act and react. And you guys are not seeing the thread here, but we're chatting about Monica
We
started
getting
off with wanting a
shirts, and all
t-shirt.
y'all just be mad. We getting shirts, okay? Either get a shirt or not. But I want CFHA merch shirts. Have we ever had
Yeah,
a
All right.
CFHA shirt?
I'm going to
Yeah.
commit to you. I'm going to commit
merch.
to you. We're going to, and maybe we can ask our listeners and you guys, right? Because I think we're collaborative. Like, give us ideas. What should be on our
Yeah.
t-shirt?
Yeah.
We will
Yes.
do a t-shirt.
Because I
Yeah.
said I was
But-
going to wear a different t-shirt every day. One day I was going to wear PCBH at the conference. Next day I'll wear collaborative care, integrated care. Then who
Yeah.
said it? Someone said, well, what if there's a shirt with all of them on it? And I'm like, oh,
That was Grace, of course.
Grace. I was
Yeah.
like, yeah, give it to
Yeah.
me.
Put them all together. We need all of us. I have a quote on my desk that says, all of us are better than any of us. And I really just deeply believe that that's true. No matter what setting we're talking about, no matter anywhere, I think all of us together are better. And so, oh, that feels like maybe a good place to end our podcast. I have loved this conversation so much. I knew I would. I always do. And I really, again, encourage our listeners, if you're not already getting those listserv emails, if you're not already spending time there, it's a good place to learn and to grow and to share ideas. And it gets a little spicy sometimes, occasionally, but we come out better for the conversation, I think. This work that we're doing, last weekend I had a long car drive by myself, and it had been a minute since I listened to Hamilton really loud. And so I was listening to Hamilton, and I'm just struck by, there's the part where like the revolution's won, and now they got to get to the business of figuring out what that looks like and what it looks like in practice, and real people with real ideas. And it's not a theoretical anymore. And that's true. Will always be true in our democracy. And it's always true in figuring out integrated care too. We got to get down and do the work. And I think that this conversation is really helpful, but it's helpful in the way that it brings us together and in the way that we learn from each other. So I hope that's been the case for you as you've listened to our episode. And I'm always so thankful for the time that you spend with us, and thankful for the opportunity to get to keep having these conversations. So thank you to you, our listeners. Thank you to each of my co-hosts, and we'll talk to you again next month.